everyone. My name is Jaikirshan. I'm an interventional cardiologist. I practice primarily CTO intervention as well as high-risk PCI. I have a lot of experience using multiple devices for coronary intervention, and I've been quite struck by the utility of the NHancer RX, and I want to share some information on this product with you and then go through some real-world examples of how I found it to be particularly useful in my practice, and hopefully you'll find some of this information useful as well. So without further ado, let's get into the presentation. So the NHancer RX is a type of a dual lumen microcatheter. I think that there are some potential design advantages of NHancer RX over some competing products, and we'll get into some of the exact details on what those are in the slides coming forward. But it is essentially a dual lumen microcatheter designed to have one over-the-wire port for your second wire and a rapid exchange port for the first wire. There's some clear design differences of NHancer RX over some competing products. First of all, the over-the-wire port comes with a stylet, which is removable, and I think that this is substantially improved the deliverability of this dual lumen microcatheter. It allows for deliverability through tortuosity and some tight lesions and calcium, and makes this option much more applicable to different disease scenarios. The tip is tapered like most microcatheters are. There's obviously an end hole for the rapid exchange port, and 6.5 millimeters proximal to the end hole, there's a side port for the over-the-wire port, and that's where the second wire will exit from. This is sort of a cross-sectional profile of the dual lumen microcatheter. The NHancer RX is not round, it's oval, because there's obviously two wire ports. One's rapid exchange and one's over the wire. The big advantage that I see of this device over some other products that are on the market is the low profile crossing area of this catheter. It's small enough that you can reliably trap this out in a 6 French guiding catheter, which is pretty unique. That's not always possible with some of the other devices that are currently available, and you can see them in comparison on the right panel in cross-sectional profiles. So that's one clear advantage of NHancer RX, and as well as the recross catheter, which is a catheter we'll go through in another presentation. So if you go into some of the fine points of the construction of the device, there's braiding that goes almost all the way to the tip of the microcatheter, which tremendously enhances deliverability and also helps to maintain the luminal integrity of the catheter so that the wires are free and torqueable, and you don't lose any of the advantage of whatever wire that you're trying to use in terms of manipulating it through a lesion. There's also some flat wires that are in the more proximal part of the shaft that also tremendously improve the deliverability of the device to the area of interest. And lastly, there's this stylet, which also improves the support and deliverability of the device to the area of interest. Once you have the device where you need to go, the stylet can be removed and then a second wire can be placed through there. Now, if you look at the device under X-ray, it also is a little bit different than some of the competing products that are available on the market. Obviously, the tip is radio opaque, but there's also a little bit of a cutout where the side port is, and you can see this on X-ray as well, which is quite unique. That's not always readily apparent on some of the competing devices, but in theory, that could be of utility. I don't know that the orientation of the side port is something that you can select. The device isn't torqueable, but it is always nice to know exactly where the wire is going to exit in relation to the tip of the microcatheter. So what are some examples of scenarios where a dual lumen microcatheter could be helpful? There's day-to-day application as well as CTO specific applications. So from a day-to-day standpoint, if you have an awkward takeoff of a side branch, you can dramatically enhance the support of a second guide wire using the NHancer RX in the main branch, as you can see in this illustration right here. If it's an extremely awkward takeoff, like a backward bend side branch, you can actually do what's called hairpin wiring or reverse wiring with a dual lumen microcatheter. And I'll show you some specific examples of how I like to do that in the slides coming forward. And the last thing that I think is pretty helpful is that you can use the side port to deliver contrast and or drug. So let's say you're doing a STEMI case and you have slow flow. You can actually put an enhancer RX in the distal bed and give a bunch of vasodilators if you want to help restore distal flow without ever having to lose wire access. So I think that's a really handy um, way of using the device that doesn't really involve another wire, but it gives you the ability to give drugs distal to an area of stenosis without having to lose wire access. And the more interesting things, at least for my practice, is the CTO application. So if you have a CTO that's got a blunt cap and there's a side branch, you can use a rapid the enhancer RX through the over the wire port to really be quite aggressive with your wires for penetrating the cap. So you put the enhancer RX in the side branch and then use the over the wire port to have very aggressive push with your penetration wire. If you get subintimal or extra plaque with your primary wire, you can put an enhancer RX into this subintimal space and then use the side port to parallel wire to get across the CTO. And lastly, once you cross a CTO, there may be an important side branch. This comes up often in the distal right coronary artery if you cross an RCA CTO and say you get into the PL branch or the PL and you need to rescue the other branch. You can use an enhancer RX to get through the dissected area of the CTO and get access to the true lumen on the distal side to deliver a second wire, which then can be manipulated into the side branch. And I'll show you some examples of this as we go through the presentation. So the first part of the talk will be about side branch anchoring. So dual lumen microcatheter can dramatically enhance the torque response and pushability of a wire that's in the over the wire port. And that's really what we're trying to do. And the orientation of the side port is generally not predictable, and it's not particularly important. I'll show you exactly what I mean by that. So the idea here is that you have, say, a blunt CTO with a side branch at the CTO proximal cap. So you can put the enhancer RX in the side branch and then use the over-the-wire lumen to introduce a stiff penetration wire. The over-the-wire lumen really improves the pushability and penetration force of the penetrating wire. And that's really what we're trying to do here. And having a wire that's anchored in the side branch can further improve the overall backup support and prevent things from backing out. And you can really engage a lesion aggressively with this setup. So here's sort of a real world example of this in action. So this is a patient with an RCA CTO that has really limited proximal artery to work with. So there isn't going to be a lot of purchase to get a microcatheter supported to really start digging into this lesion. But what we do have is a side branch that we can access with a wire and then put in a dual lumen microcatheter, enhancer RX in this case, into that side branch. And that can lock us in so that we can be much more aggressive with what we want to do with the proximal cap. So this is an example of delivering a penetration wire through the over-the-wire port of the enhancer RX after anchoring everything through a side branch. And in this case, after we penetrated the cap, we actually pushed a jacketed wire to form a knuckle because the course of the vessel wasn't entirely clear. But the point is that the wire that's in the side branch with the enhancer RX are providing all the support that we need in an artery that there isn't a lot of purchase in to be very aggressive. First with a penetration wire, and then secondly with a knuckle wire to force our way down the artery without the guiding catheter backing out. So it's a really nice solution for these types of scenarios. Now, once we were knuckled adequately into the artery, as you can see in the left panel, we were able to straighten the knuckle out and just wire into the lesion. So if you look in the right panel, you can see that we actually were able to basically re-enter using the knuckle wire and get back in. But ultimately, all of this was being performed with the support of an enhancer RX and a side branch with very little guide catheter purchased within the artery itself. So some pretty aggressive maneuvers that can be made possible just by the anchoring ability of a side branch and a dual lumen microcatheter. Another really interesting scenario that comes up in a stumpless proximal cap CTO that has a side branch is to use intravascular ultrasound. So one of the challenges that we run into CTO is that, yeah, you can penetrate the cap with a stiff wire, but you have to have a good idea of where to puncture. And this can often be very difficult to understand if the cap is entirely stumpless, if there's no beak to aim at. So we use intravascular ultrasound quite liberally for this problem. And you can make IVUS guided puncture much more effective if you do it in conjunction with a dual lumen microcatheter like NHancer RX. So in our lab, the typical setup is if there is a side branch at a stumpless cap, we'll put a workhorse wire into the side branch. Once we have the workhorse wire down the side branch, we'll load a Boston Scientific IVUS probe to visualize the proximal cap off of the side branch, which you can see in the inset on the right. We'll load an NHancer RX on the very same wire until it butts up into the IVUS catheter. And when you do this, in this configuration, the exit port of the over-the-wire lumen is roughly where the imaging element of the IVUS probe are. And you can see that in the schematic. So once you have this situation, you can load a penetration wire through the over-the-wire lumen of the NHancer, and you'll actually see it in real time on the IVUS, and you can manipulate the wire. And if you need to, you can even move the NHancer back out of the way to have a little bit more space to manipulate the wire. But at all times, you have all the support of the over-the-wire lumen, all the torque response of the over-the-wire lumen, the anchoring of the side branch, and the direct visualization of what your penetration wire is doing. So you can, with a very high level of confidence and accuracy, penetrate the proximal cap. So here's sort of a real-world example of this scenario. So this is a patient with a stumpless proximal cap, RCA CTO, with a really decent-sized side branch. And you can see it in LAO and REO. So the challenge with these type of cases is it's often very difficult to understand how to puncture and remain coaxial with the plaque. And remaining coaxial with the plaque is really what improves the likelihood of tracking plaque and re-entering spontaneously on the distal cap side. So this is the setup that we would use to approach this type of a lesion in our lab. So first, a workhorse wire is put in the side branch. IVUS is placed in the side branch to visualize where the cap is. And so you can see on this inset, the IVUS is in the RV marginal branch, and then you can see the cap of the CTO. And so to puncture the cap, what we do is we'll bring an NHancer RX in all the way to the end of the IVUS. Okay, so the NHancer will bump into the IVUS on the very same wire. And then we use the over-the-wire lumen to introduce our penetration wire. And now we can see with real-time IVUS that we're actually puncturing. So this bright white dot here in the inset is the penetration wire. And you can see that we've actually punctured the cap. So you have all the support and anchoring of the side branch and the dual lumen microcatheter. You have all the wire support and torque response of an over-the-wire lumen for your penetration wire. And now you have the intravascular imaging to verify that what you're doing with your penetration wire is actually correct. So it's sort of a triple threat. It's a way to be very, very aggressive and also be very safe and accurate in a stumpless puncture. And so after we puncture, we use a trapping balloon, and you can use a trapet or whatever balloon you have in your lab to remove the IVUS and the NHancer RX, and we put it in a conventional microcatheter and swapped out to a jacketed wire. And you can see that this jacketed wire, after that coaxial puncture, just was able to re-enter quite nicely into the distal vessel. So just a nice example of how you can make a pretty complicated procedure quite safe and effective using a couple of simple tools that you already have in your lab, but maybe don't think about using in combination together. So the other big scenario that we use dual lumen microcatheters for a lot is retrieval of a side branch. So the NHancer RX or any dual lumen microcatheter can be used to deliver a second wire to the area of interest. It can be reshaped as needed. Once the second wire is delivered to the area of interest, so once you're beyond the CTO into the true lumen distally, the dual lumen microcatheter can honestly be removed. It doesn't need to be back there. Once the wire is where it needs to be, if you leave the dual lumen close to where the wire is, then you have a lot of support. If you pull the dual lumen back, you have a lot more space to manipulate the wire. So it sort of depends on the scenario. And ultimately, what I would tell you is that the orientation of the side branch is honestly not important. It really doesn't play into how useful the device is. You can use this to access retroflex side branches when conventional wiring is unsuccessful. And you can use this to control a side branch after you cross the CTO and aren't sure that you have full control of all the important branches. And here's some examples of this in cartoon form. So this is a case where a CTO successfully crossed into one branch, but we need to make sure we have control of the other branch. So what is typically done in this case is an NHancer RX is delivered to the distal bed. We deliver a workhorse wire to the distal bed, and then you can pull the NHancer out of the way and just use the wire to get into the distal bed. It really doesn't matter which way that side port is pointing. As long as the wire is already in the true lumen distally, it's usually quite effective. So let's show you some real world examples of this. This is a case of a LED CTO that was done retrogradely. And you can see that the septal that we use to cross is pretty proximal in the LED, and we need to control the distal bed of the LED. So in these scenarios, what we generally will do is we'll use an enhancer just to deliver a workhorse wire. So in this case, the enhancer was used to deliver a workhorse wire antegradely into the septal. Once the workhorse wire is there, I really don't need the enhancer anymore. I can pull it out of the way, and that way I have a lot more room to manipulate the wire, and I don't need to worry about the orientation of the side port. So once the enhancer is pulled out of the way, if you look in the right panel, I just pull the workhorse wire back and just probe until I can get control of the distal LAD. And if for some reason this doesn't work, you can do this over and over again with the enhancer. There's no reason why I couldn't do this over again if I thought I'd pulled the wire back too far. But this is a nice way to get a wire beyond the area where we had done the reverse cart. So the reverse cart was done in here, and it's often difficult to cross this antegradely without getting hung up in the dissection flaps. So the enhancer bypasses all the dissections that we created, safely delivers a wire into the true lumen distally. Then we pull the enhancer out of the way and just use the wire to do the rest of the work. The hairpin wiring technique is something I think is also quite handy with a dual lumen microcatheter like enhancer. Now this is for a retroflex side branch, something that's really going to be difficult to wire antegradely. And for this, we generally will use a polymer jacketed wire. So I'll put a workhorse bend on the polymer jacketed wire, and then about 20 millimeters proximal to the workhorse bend, I'll put a second bend that's relatively soft. And I'll put this through the over the wire lumen of the enhancer. So this is what it would look like. So this is the soft bend, and that's the workhorse bend, and all of it's sticking out of the over-the-wire lumen. So the stylet is now being replaced by this wire. And then I load this entire thing through the rapid exchange portion, and you'll see in this video how this will work. So once this system hits the TUI, the wire folds over on itself and has to come backwards. And this is a video on the right side of what this would look like on the guide catheter side. So imagine that you push the wire through the guiding catheter with this backwards fold on it. This is what the wire is going to look like when it comes out of the guiding catheter. So when you drag this type of a setup backwards, you can hairpin an awkward side branch. And I'll show you exactly how this looks like in the real world. So in the left upper panel is our target, this rather awkward backward bent branch that was not wireable by another operator, and it was referred to us for a second attempt. And in the center panel, you'll see us delivering our hairpin wire on the enhancer RX. This is what it will look like as it comes out of the guiding catheter folded over on itself. So the enhancer is used to deliver the hairpin beyond the area where the branch bifurcates. And once I get this working end of the hairpin beyond the area of interest, I actually pull the enhancer out of the way so I have a little bit more room. And I just use the hairpin to do the work. So if you look in the right panel, you'll see the enhancer has actually been pulled out of the way. And I'm just using the hairpin wire, rotating back and forth and pulling and pushing until I can see it catch. And you can see it's not always going to catch on the first try. You just have to be patient. And with a little bit of trial and error and just taking your time, it's usually quite readily will access the side branch. And I wanted to show you this one because it's not always going to happen on the first attempt. It may take a little bit of back and forth, and you see it finally pops in. And all I'm doing is pulling backwards on this wire, and it just keeps tracking down that side branch. So this is a really, really powerful tool that we use quite a bit for awkward side branches, and I think is quite reproducible and can be a really, really helpful tool in the bind. Here's sort of an extreme example of this. This is a patient with a vein graft that's failed and has a circumflex CTO. And we used a hairpin technique twice in one case. So this is the first hairpin that's being delivered down the occluded vein graft to get backwards into the circumflex. So once I get the hairpin beyond the distal graft anastomosis, I actually pull the enhancer out of my way. So now we've got the wire back beyond the anastomosis, pull the enhancer out of the way, and then I pull the wire back, and then it can access the circumflex. And then once we got going on the circumflex and did a reverse cart, we saw that there was another very important branch that we needed to control. So now we did an antegrade hairpin. So this is a hairpin coming the opposite direction to try to access a branch that's down here. So again, I get the hairpin beyond the area of interest, pull the enhancer out of my way, and then I pull the hairpin back until I can catch that branch. And again, I want to emphasize, it doesn't always happen on the first try, and it takes a little bit of patience, a little bit of confidence that the technique will work, but you'll be surprised at how effective it is. I share this case specifically because this is where we used it twice on the very same patient during the same procedure, and it worked both times. So it's something definitely to keep in your back pocket for these sort of awkward angles where you need to control a branch. And as you can see here, it's not immediate. It's just a little bit of probing until we can get control of that branch, and you can go back and forth until the wire behaves the way it needs to. And you can see you can do this over and over again until it looks right. And you'll see at the very end of this fluorosave that we finally do catch the branch, and the wire immediately pops into the area of interest, which we're going to see right here. So once you catch it, you just pull back on the wire and it'll just go into the side branch. So that's a double hairpin in one patient to fix a circumflex CTO. Another great scenario where NHancer RX is quite helpful is in cases where a proximal cap puncture results in a subintimal wire position. So the natural tendency when this happens is to set up for a device-based reentry, or some people like to just reprobe. One of the issues with reprobing is that the more times you puncture this cap, the more likely you are to create a hematoma. And eventually, the hematoma is going to compress the distal target. And that's what we're ultimately trying to avoid, no matter how you try to cross the CTO antegradely. I really like parallel wiring. I think it's a really helpful tool and a nice crossing strategy when you have the right set of circumstances. So in these types of scenarios, when I have punctured a proximal cap and go subintimal, as you can see in the left cartoon, what I think is really helpful to do is to leave this wire in position and don't make any more punctures, because the more punctures you make, the more likely you are to create hematoma. And I think that the wire is an important tool because the wire now marks where we don't want to go. And what we really want to do is puncture the proximal cap again, and hopefully in a more favorable way. And a dual lumen microcatheter like NHancer RX is a great option in these types of scenarios. So we leave the subintimal wire in position, remove the conventional microcatheter, put it in a dual lumen microcatheter like the NHancer, and now use the over-the-wire port, which will give you lots of backup support and good torque response for a penetration wire to puncture the cap a little bit differently. And I know it's going to be different because I have the first wire still in place to mark where I don't want to puncture. And so now this second wire, which I can be very aggressive with, can be directed in a slightly deviated position across the proximal cap. And once I've punctured in a slightly different way, we can continue on with this wire, but what might be more safe is to swap it out to a jacketed wire and then probe. But this is a nice way to perform parallel wiring without having to worry about how to maintain the position of the first wire, which I think is an important wire. It's almost like a guardrail to tell you where you don't want the second wire to go. And a dual lumen microcatheter like NHancer really facilitates this. And then in the next slides, I'll show you some examples of how we use this in the real world. And so this often comes up in these types of scenarios. So this is a case of an in-stent restenosis CTO where we crossed really pretty quickly and could not get anything to cross the CTO. No microcatheter or balloon would cross. And the reason it won't cross is because we've probably gotten under a couple of struts in this old stent. So you could obviously pull this wire and do it again, but what I think is a lot more efficient is to leave the first wire in place and put in a dual lumen microcatheter like an NHancer. So in the left panel, this is an NHancer at the proximal cap, and now we're probing again with the second wire. And the idea here is to make this wire go someplace a little bit different than the first wire. So that's what you're seeing. There's a considerable amount of deviation between the second wire and the first wire, and then they start to meet again once you're through the CTO. So now the second wire has taken a completely different path, and you can see that in this frame that I saved here. There's quite a bit of divergence through that stent. And now it was very easy. So I left both wires in place. Now you can see that a microcatheter very easily crossed. So the first wire had basically gotten underneath some metal. And this frame on the right shows you again, there's this gap between the balloon on the second wire and the original first wire. That gap is because the first wire must have inadvertently gotten underneath some struts. So it's a nice way to kind of bypass these types of problems without having to make the procedure unnecessarily complicated. So in conclusion, I would tell you that NHancer RX is a super versatile tool that's useful in both day-to-day PCI as well as CTO procedures. I gave you several examples of how you can use this for both anchoring a side branch as well as how to rescue a side branch. I think one of the key advantages of the device is the low profile crossing profile and the high pushability of its construction. So you can take this device to places where other dual lumen microcatheters may not be able to track, and you can trap this out with a 6-French guiding catheter, so you don't have to be worried about how you're going to retrieve the catheter once you have your wires where they need to be. And with that, I will just stop with this sort of schematic of some of the dimensions of the device, and would be happy to answer any questions that you have for your local Biotronic reps who can relay them to me, and we can try to clarify any questions that come up in the future. Thank you so much for your attention.